Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Charles Hawley, NAUTO's Director of Projects, who will start today's session. Charles, you have the stage.
Thank you, Maren, and thank you everyone for joining us today for the symposium on using data to address healthcare inequities and their causes. Our last symposium session was really great on the use of race data, and now we get to talk about social determinants of health. So I think this is going to be a really excellent next session. I want to take just a brief moment to thank our sponsor, Comagine Health. We really appreciate all of our sponsors and encourage everybody to visit those booths. And then without any further ado, I will introduce Starla Ledbetter with the California Office of Statewide Health Planning and Development.
Hi, good afternoon, and welcome to our session on social determinants of health and health data. As Charles mentioned, I'm Starla Ledbetter, Chief Data Officer of OSHPD, but we're transitioning to a new name, the California Department of Access and Information, HCI. And I also serve on the NAUTO board. And I would also like to extend my thanks to Comagine Health for sponsoring our time here together. So we'll jump right in. Our first presentation will be on the Community Connector Tool, which was the winner of the AHRQ Social Determinants of Health Data Visualization Challenge. Margaret, Loa, and Kelsey Skvoretz will be presenting. They are both data scientists, and you can read their full bios by scrolling down below the presentation window on the conference platform. Also, we have the chat window open. As a question comes to mind, please go ahead and add your questions to the chat.
Hi, my name is Margaret Loa, and I'm a data scientist at Mathematica within the Health Improvement Division. Today, with my colleague, Kelsey Skvoretz, I will be presenting the Community Connector Prototype Tool, which was the grand prize winner of the Agency for Healthcare Research and Quality's Visualization of Community-Level Social Determinants of Health Challenge. In March 2019, the Agency for Healthcare Research and Quality, or AHRQ, announced their Visualization Resources of Community-Level Social Determinants of Health Challenge. They sought a visualization tool that supported visualizing social determinants of health and community service digital datasets to enhance their research and analysis of community-level health services. At Mathematica, we formed a team of data scientists, researchers, and designers to work on a prototype submission for the AHRQ's Visualization Challenge. We aim to build a common definition of local social determinants of health and a way to identify communities with similar needs and demographics, particularly those that have had success in addressing social needs and improving health and well-being. We built our Community Connector prototype using county-level data from the state of Colorado to allow local user testing and to incorporate local government data. Our prototype was developed such that the county-level data could be easily replaced with data from any other state. Similarly, we focused on health outcomes related to obesity, diabetes, and kidney disease with the idea that the tool could be repurposed to any other health outcome in the future. We chose obesity, diabetes, and kidney disease for the prototype since these health outcomes have similar risk factors and preventative strategies. And evidence has shown that they are associated with higher health costs and utilization. Additionally, Colorado's Department of Public Health and Environment lists obesity as one of their top 10 winnable battles. The department selects these winnable battles because they offer the greatest opportunities for ensuring the health of Colorado's citizens and visitors and improving and protecting their environment. Many of Colorado's winnable battles, including obesity, align with the winnable battles of the CDC. AHRQ selected the Community Connector prototype submission as the grand prize winner of the Visualization Challenge. The prototype provides outcome-agnostic county-level scores for 6 domains of social determinants of health, which were identified by the Kaiser Family Foundation, identifying the county's relevant strengths in this domain. The tool identifies Colorado County matches based on similar demographic and social determinants of health characteristics relevant to obesity, diabetes, and kidney disease, relying on machine learning algorithms to encourage comparisons of health outcomes and collaboration across counties. Our tool caters towards the following groups: local government officials and public health officials to potentially aid them in selecting and funding programs that align with the priorities of the constituents they serve; state and federal regulators and policymakers to potentially aid them in describing the needs of target communities and assessing variation in outcomes when designing or incentivizing programs that involve community-based interventions; individual researchers and healthcare payers, care delivery organization, and community-based organizations to potentially aid them in completing community health need assessment requirements or developing assessments and evaluating their progress towards established goals regarding social determinants of health. We now take a closer look at the data and methodology used to create the Community Connector prototype. We pulled data related to demographics, social determinants of health, and obesity, diabetes, and kidney disease using a variety of publicly available data sources. AHRQ's Visualization Challenge required the solutions to use only open source data. The data sources include the American Community Survey, CDC's Diabetes Atlas, and Colorado's Department of Public Health and Environment. The Community Connector prototype integrated multiple methodological components. First, creating social determinants of health scores through defining domains of social determinants of health and selecting variables across these domains, identifying similar counties, and exploring health outcome variability. First, we used the 6 domains of social determinants of health identified by the Kaiser Family Foundation as the basis for the Community Connector social determinants of health scores. The domains are economic stability, neighborhood and physical environment, education, food, community and social context, and healthcare system. As previously mentioned, we selected data from a variety of data sources to develop standardized scores for each county across these domains. I will now pass the presentation over to my colleague Kelsey to present on our variable selection methodology.
Thanks, Margaret. To select the variables from the publicly available data sources for each social determinants of health domain, we used sparse principal component analysis. Sparse principal component analysis is an unsupervised learning approach for dimension reduction. It finds a linear combination of variables that best represents the variation in the data, while also forcing some of the variable loadings to 0. After reviewing the variables selected by sparse principal component analysis for each score, we assigned a few additional variables that were not selected based on existing research and literature, a strong association with general population health, or both. Additionally, we ensured that variable selection and score creation did not depend on obesity, diabetes, or kidney disease, so that this tool could be easily translated to other health outcomes. To create scores for each domain of the social determinants of health for each county, we assigned a direction of association to each of the selected variables and normalized each variable's distribution. The county-level domain scores are a weighted average of the normalized variables and are adjusted for the economic status of the county. The final scores for each of the 6 social determinants of health domains are on a 0 to 1 scale, representing worst to best, and are independent of the health outcome in question. The fingerprint chart on the right visualizes this county's social determinants of health scores. Axes expand from 0 to 1. Scores closer to 1, the outer circle, indicate the county is strong in that area. For example, this county has a high score in the economic stability domain. Scores closer to 0, the center of the circle, indicate the county is weaker in that area. The Community Connector prototype uses these social determinants of health fingerprints to provide a list of counties that are similar to the selected county of interest. The goal of this matching approach is to provide a list of similar counties using only the characteristics a county cannot easily change, such as demographics and non-modifiable social needs. Peer counties that have implemented programs to improve modifiable social determinants of health characteristics can serve as reasonable comparison counties. To identify similar counties, first we identified modifiable and non-modifiable variables, or variables that counties cannot easily change, based on literature and intervention feasibility. For example, county budget and percent spent on health are modifiable variables, whereas population and percent rural are non-modifiable variables. We then fit a lasso regression model to predict the health outcome in question based on this equation on the slide. Here, Y is a health outcome for County I, in this case, % overweight or obese, and X are their demographic characteristics. Lasso regression performs variable selection and regularization as the fitting procedure shrinks coefficient estimates towards 0. We then used the demographic and non-modifiable variable data, along with their coefficients from this model, beta and gamma, as weights to calculate the Euclidean distance between counties. This returns a measure of similarity between counties using only the characteristics they cannot change, weighted by their importance to the health outcome in question. Methodology acknowledges that some counties might face more challenges in addressing social determinants of health. Therefore, counties are not to be compared to those with a much higher socioeconomic status, as interventions and programs across counties may not impact different populations in the same way. In this image, we present a selected county in yellow overlaying a selected comparison county in teal based on this algorithm. The Community Connector prototype also presents the distribution of the health outcomes related to obesity, diabetes, and kidney disease across all counties in Colorado. For example, on the left, the top density plot shows the selected county's % chronic kidney disease in Medicare age 65 plus as the yellow diamond and dotted line compared to the gray distribution of the outcome across all counties in the state. On the right, the top teal colored density plot visualizes distribution of this health outcome across the 20 matched counties, overlaid on top of the gray outcome distribution of all counties in the state. The teal diamonds represent the outcome rates for each of the top 20 similar counties, and the dark green diamond and dotted line represent a selected comparison county's outcome rate. The Community Connector prototype is currently available to view by the public through this website. Mathematica created the Community Connector prototype with intentional goals and uses, and there are also potential future expansions for this tool. The Community Connector is intended to help users understand heterogeneity across community needs and outcomes. This tool can help users understand community differences and explore where similarities lie. As we assessed usability of the tool, we incorporated feedback from a variety of stakeholders. From this feedback, we created an easy-to-use tool that displays the graphics and instructions in the most comprehensible way. As a result, the Community Connector has had over 71,000 views since its launch in mid-December 2019. The tool was developed to be a highly scalable application that is flexible enough to incorporate future user needs and features. For example, the tool can be expanded to include data from all communities across the United States. Additionally, the Community Connector could integrate analyses of a wider range of health outcomes and service use data. While the Community Connector prototype is an interactive tool with interactive visualizations using static data, future iterations could enable policymakers, researchers, and practitioners to upload their own county-level data to further customize their search for similar communities. In the future, it could even provide opportunities for similar counties to collaborate with each other to solve challenges that their communities share. Finally, I'd like to acknowledge my colleagues at Mathematica who contributed to developing the Community Connector prototype. Thank you for your interest in the Community Connector.
Great presentation. That is an exciting tool to have available. Just to remind folks, if you have any questions for our presenters, to please put them in the chat. I'm just curious, so at the website that you displayed, can folks sign up to get notifications for when there's updates to the tool? Like you mentioned in the presentation, people at a future iteration would be able to utilize the tool with their own data?
Yeah, we don't have any feature right now to sign up for updates, but you can certainly email us and check in about future timelines.
Awesome. So we do have one question, a couple questions coming in. How often will the underlying public data be updated? For example, like the Census 2020, things like that.
Yeah, I can answer that question. So the updates to the prototype are on an ongoing basis. And again, we don't have a feature to notify individuals of changes, but it would be in the documentation on the website if we made any changes to the data sources that we've used.
Okay, thank you. Another question, I haven't looked at the website yet, but are there features for users to discuss the visualizations and exchange opinions?
Yeah, so we have some of the documentation on the website as well as a link to our GitHub where you can submit issues or questions that you might have, as well as our contact information is great as well. We would love any sort of feedback. So.
All right, great. Well, thank you both so much. And we'll go ahead and move on to our next presentation. Our next presentation is exploring social determinants of health through administrative claims and large healthcare data. Wyatt, Bensken, and Martin Kosla will be presenting. Wyatt is a doctoral candidate in epidemiology and biostatistics at Case Western Reserve University. Martin is a business intelligence analyst at the Michigan Data Collaborative. Full bios can be found on the conference platform if you scroll down below this window. So with that, we'll move to the next presentation.
Hi, thank you so much for coming to my talk. My name is Wyatt Bensken. I'm a PhD candidate in the Department of Population and Quantitative Health Sciences at Case Western Reserve University. And my talk, the first half of this talk, is about social determinants of health and administrative and large healthcare data. So I'm sure we're all aware, but just so we're on the same page, the social determinants of health are recognized as critical components of health, and they're defined as the conditions in which people are born, live, learn, work, play, worship, and age. And in my work, we use this term health-related social needs. And the idea is that these are the needs that an individual patient has that are a result of a fundamental cause of health and the social determinant. So with the introduction of ICD-10 in October of 2015, there was a new class of diagnosis codes aimed to capture the social determinants and Hrsn. These start with the letter Z, and so we refer to them as Z codes. The idea here was that by creating ICD-10 codes, which was a format familiar to all physicians, clinicians, and researchers, we could have a standardized way to collect this information. They've gained a lot of attention recently from a number of leading organizations you can see listed there. Additionally, there's been two reports that I want to call to your attention: a March 2020 report from the Assistant Secretary for Planning and Evaluation and a July 2021 report from the National Quality Forum. Both of these looked at the role of social risk in value-based purchasing. So ICD-10 codes here, the Z codes we're talking about, you can see listed here and relate to everything from problems with education and literacy to economic circumstances to psychosocial circumstances. So now I want to kind of briefly go through some research that me and two of my mentors have done, and this was published in the Journal of General Internal Medicine, and there's the citation. So we used the 2017 nationwide readmission database from AHRQ, which included just under 18 million hospital discharges of over 13 million unique individuals. We identified, using those ICD-10 Z codes, 5 domains of health-related social needs that you see listed on screen here. These were adopted from a report out of the Missouri Hospital Association by Matt Reedhead, and the citation is down there if you'd like to read more about that. So our first question was, are Hrsn or Z codes being used? So overall, we saw that 97.6% of patients did not have any of the 5 Hrsn domains. But because we had such a large database, we did see a substantial number, over 200,000, who had one of the domains. And you can see there 1 through 5. So a very small number, but some individuals did have all 5 domains of Hrsn recorded. But overall, it was just over 2% of patients. What did these patients look like compared to the general population? On the left-hand side, we see that 56% of those patients with Z codes were male compared to only 40% of those without Z codes. Additionally, we see an overrepresentation of Medicaid, other, and self-pay as the primary insurers, and an underrepresentation of Medicare. Additionally, we have the Elixhauser comorbidities here. So these are a set of commonly used comorbidities. And I'm just drawing your attention to specific comorbidities, including alcohol abuse, depression, drug abuse, and psychoses, where we see a pretty substantial difference in the prevalence between those patients with Z codes, which are the orange dots, and those without, the gray dots. Finally, we wanted to look at the relationship between health-related social needs and readmission. In this figure, we have each panel, which is 30, 60, and 90-day readmission. The y-axis is the percent of patients with the readmission, and the x-axis is the number of domains. It should be abundantly clear here, just from looking at this, that we have a clear dose-response relationship, where for patients with no Z codes, we saw about 11% had a 30-day readmission, and this jumped up to almost 65% for those with all 5 domains. But even those with just one domain had over 25% of those patients had a 30-day readmission. We also used logistic regression to examine this relationship. Here we see our adjusted odds ratios. We adjusted for sex, age, insurer, site of care, functional limitations, and those comorbidities I just showed. And it's quite clear here that compared to patients with no Z codes, those with just one of those domains have 2.2 times the odds of a 30-day readmission, again, increasing up to 12.6 times the odds for those with all 5. So what were our conclusions from this work? First, we saw that Z codes are not really commonly used. Second, we saw this clear dose-response relationship with readmission. And there's 2 limitations here I want to highlight. The first is that more visits to a care provider may mean more attention to those Z codes and more likely to receive a health-related social need diagnosis. And we were unable to assess acute versus chronic, as well as the timing of these Z codes with respect to readmission. So these are kind of areas of future work, but overall, we think we have a very nice story here that shows the utility of these Z codes. I'd like to thank my 2 co-authors, my mentor at CASE, Dr. Saran Krukian, and my mentor at the AMC, Dr. Philip Alberti, and my contact information is there at the bottom of the slide.
Hi, my name is Martin Kosla. I'm the Business Intelligence Analyst at the Michigan Data Collaborative. And over the past year, my team and I have conducted a very complementary analysis to the one that Wyatt just presented. We leveraged data from Michigan's Comprehensive Primary Care Plus initiative, our CPC Plus, which includes both commercial and Medicare patients. And by analyzing their claims, we were able to identify approximately 18,500 patients with a health-related social needs diagnosis. This prevalence is 2.5% of the total CPC Plus population in Michigan. And that prevalence is actually right in line with what Wyatt had observed with his data source. And while this prevalence is low, suggesting that Z codes aren't being utilized too frequently, we did find evidence that their use is increasing over time. So the top line here shows the total number of patients with a claim with a social needs diagnosis every month, and the bottom line are patients being diagnosed for the first time. So every month we're identifying and diagnosing between 400 and 500 new patients with a social need. In terms of who's being diagnosed, on the left hand here, we see that in contrast to Wyatt's data, ours tends to be more female than male, largely driven by diagnoses in that family domain. And while we looked for variation across different types of communities, specifically metropolitan, micropolitan, and rural communities, we didn't see much variation in terms of overall prevalence. A shortcoming of this geographic analysis is that we did measure this at the county level, and there is research to suggest that characteristics like rural are better measured at a census tract level, but those data weren't available to us. In terms of which diagnoses we're actually seeing in our data, the most frequently used diagnosis was disappearance and death of a family member, followed by problems related to living alone and problems in relationship with spouse or partner. The color coding on this graph indicates whether that diagnosis was a detailed diagnosis, like problems in a relationship with spouse or partner, or a other or unspecified diagnosis, like other problems related to social environment. And of the top 10 diagnoses, 5 of them fall into these catch-all other or unspecified diagnoses. It's a little unclear why these diagnoses are being used so frequently. It's entirely possible that coders are just defaulting to these more general codes, or this could reflect a shortcoming in the other existing Z codes that maybe they're not adequately capturing the social needs of our patients. Finally, like Wyatt, we did explore the relationship between social needs diagnoses and utilization. We looked at emergency department visits and acute inpatient admissions, not readmissions, just any admissions. And we did find that our social needs population did have significantly and substantially higher utilization rates for both these metrics. However, in our full models, we did conduct logistic regressions, controlling for risk. We were able to identify some subgroups within that social needs population. And that's specifically whether a patient received their first social needs diagnosis on a facility claim versus on a professional claim. Patients, both of these groups did have significantly higher odds of experiencing a emergency department visit during a given reporting year, but it was only those who received their first diagnosis on a facility claim who were significantly more likely to experience an acute inpatient admission. Whereas those receiving their first diagnosis on a professional claim were not significantly different from the non-social needs population. The big takeaways of this analysis, especially in light of Wyatt's analysis, is that using a completely independent data source, we found a similar prevalence of these social needs diagnoses. And while that prevalence is low, we found evidence to suggest that this will be increasing over time. However, many of those diagnoses fall in these catch-all categories, and additional analysis is really necessary to tease that out. Finally, we did observe a relationship between a social needs diagnosis and utilization, but we also identified some variation within that social needs population that also warrants further investigation. Thank you for your time. I look forward to hearing your questions.
Great information. Thank you both, Wyatt and Martin. That was excellent. If there's any questions, please put them into the chat. I do have one question to kind of start us off. So many years ago, I was a coder. And I'm curious to know if you noticed any geographic trends or trends in specific facilities where you were seeing that there were no Z codes reported. Are there any trends that way to kind of identify, who's not reporting?
So we did look for variation across health systems, and we do see that certain health systems have not focused as much on Z codes as others. And specifically, when we did a county analysis, we did identify several counties that we know had countywide initiatives to encourage the use of social determinants of health screenings. And those counties, not surprisingly, had higher use of the Z codes than counties without that. And so we have done some analyses around that. Okay.
So additional education out on the importance of this data collection would be helpful.
Yeah, correct. Yeah.
Great. Okay, we do have a couple questions in the chat. The first one, thank you for this presentation. Do you think Z code utilization will improve with the uptake of telehealth?
I can. Yeah, go ahead, Wyatt.
No, please go ahead.
Oh, I was just going to say that that's not something that we really looked at too much within our data. We didn't distinguish between telehealth claims or non-telehealth claims. Though what I will say is that during the pandemic, when telehealth was being picked up, we did see a drop in overall claims. But post-pandemic, where we assume to a certain extent that telehealth visits are continuing to exist, those trends didn't look significantly different than the trends prior to the pandemic. So on one of the slides I shared, I showed trends over time, and post-pandemic, like I said, where we expect telehealth to be being used a bit more, we didn't notice too much variation there, at least not yet. Wyatt, anything to add to that?
Yeah, I was just gonna kind of answer this and maybe those other two that popped in that all tie together in this issue of underutilization of these codes. They're not presently reimbursable, and AHRQ recommended in that 2020 report that you should not adjust for social factors, although the National Quality Forum is kind of gotten to a different conclusion. So there's hope that maybe if Z codes do become either reimbursable or part of risk adjustment, they could be more commonly used, which I think hits on this idea that we just know that more than 1% to 2% of patients likely have social needs. But it's really, an absence of a Z code is not an absence of a social need. There's also some work around perhaps finding ways to link documentation of these codes to social needs screening. So certainly I think all of this is kind of related to these similar issues of underutilization of Z codes.
Thank you for that. And I see one more question, a new question. What date are you using to mark post-pandemic?
Yeah, maybe I use that term a little bit too freely. In the graph, though, where I showed that was showed earlier, you will see a dip, basically a dip in all overall claims that ends that starts right around March 2020 and bottoms out around, looking at this graph, I would say roughly June 2020, and then claims and visits start increasing, and so we also see that increase in the use of these diagnosis codes. So I shouldn't say post-pandemic, but maybe even into the post early days of the pandemic would have been a better phrase for me to use there.
Thank you. All right, well, that looks like all the questions we have now. I encourage everyone to continue thinking of questions. We'll bring all the presenters back at the end of our session. With that, we're going to go ahead and move on to our final presentation for this session. It's Social Determinants of Health During the COVID-19 Pandemic. Ernie Shippey will be presenting. Ernie is a clinical research director for Vizient Incorporated. And we'll move to that presentation now.
For this analysis, Alyssa Harris and myself, Ernie Shippey, are looking at the social determinants of health and the COVID-19 outcomes. This is AHRQ's Social Vulnerability Index, their domains: social context, economic context, education, physical infrastructure, and healthcare context. To understand the differences, I picked 2 zip codes in San Francisco. One on the poorer side, higher SVI, and wealthier one. We can see the income differences, racial profiles. Then we looked at hospitalizations using our database. COVID-19 hospitalizations per million, 4,440 versus 288. This map shows AHRQ's SVI aggregated by each state. You can see some of the poorer states, Mississippi, 0.73, versus New Hampshire, which is probably the wealthiest and least vulnerable, with only 0.0724 in their index. This graph is looking at the social vulnerability index, least vulnerable to most vulnerable, and then the COVID-19 deaths per million through August. We see Mississippi here, high social vulnerability index, high mortality. We see New Hampshire here, wealthier, much lower mortality. And then we see the rest of the states here. Let's look at the largest state, same graph. These are the CBSAs. We see El Centro, California, most vulnerable, right there around the Mexico border, almost 4,500 deaths per million. And then we see San Rafael down here, a lot wealthier, much lower mortality. We see this trend right here. Same graph, this is Texas, the second largest state. We see Austin here, least vulnerable, low mortality. We see the most vulnerable here is the rural areas around the Mexican border, McAllen. We also see the highest is actually Lubbock and Amarillo. The hospitals in this area serve a rural area about the size of Indiana. This map here showing the northeast coast, and the large vertical bars are the population densities, the number of people living in each zip code. We can see New York City here, the epicenter of the pandemic. Quite a bit of rise in Bronx and Kings counties. They have a very high vulnerability index compared to the rest of New York State. We can see the deaths per million in that area is 8,000 versus 1,609. Now we're looking at this large area here, about the size of Indiana. The rural areas around Amarillo and Lubbock. Quite a bit of poverty, very large area, 200 by 200 mile area. A lot of food deserts, nursing home deserts, clinic deserts in these areas. How the most vulnerable work has quite to do a lot with their overall risk. We can see quite a few of these jobs here: construction, labor, agriculture. Quite different than folks that can do their work through Zoom. This grid here is pretty important. It's looking at social determinants of health and what we call complex patients. So using our database, we did a longitudinal study looking at patients that were admitted in 2018 and the number of repeat hospitalizations. Overall, we have around 8% of patients in our database are considered complex. But when you look at them by the social vulnerability index, we put them into quintiles here: least vulnerable versus most vulnerable. Overall, we see a much higher distribution here in the most vulnerable. The big aha here is looking at the age. We see here 64 makes sense as the health span starts to degrade. But we see here in the most vulnerable a much younger health span. It's about 10-year difference where they're starting to get more severe disease, a lot more hospitalizations, a lot more ED visits from these disadvantaged neighborhoods. This actually makes the vaccination priority. You know, most of it was 65 and older as our at-risk populations. We might want to consider the fact that the folks in these neighborhoods, it's probably more like 55 if you're living in a poor neighborhood, just due to those social determinants of health. This graph here is looking at Arc Social Vulnerability Index. Each dot here is representing a community. We can quickly see this is the COVID-19 vaccination rate for folks 18 and older, the adults, as of 8/15. We can quickly see the overall compliance. We see the wealthier neighborhoods, a little bit higher educated. We see a much higher vaccination rates here. And then we see this basically go down quite a bit as the social vulnerability index hits those communities. Once again, we have the education, we have English language issues, we have misunderstanding. They probably require a lot more education to be vaccinated. And one thing we did notice is also the spread of the Delta variant. In August, cases per million, 78.52 among the folks that are above this red line. They got vaccinated much higher, 31,149 in the ones that were in the lower vax groups. Early messaging of COVID-19 was that it was mostly a disease of the elderly. This didn't really take into account the full nuances of the lower health span that we noticed with the data. This also brought in education and messaging issues. We have some vulnerable communities. 1 in 5 have less than a high school degree, English language proficiency. But we did have 38 communities that traditionally had very low historical flu shot compliance. Yet the 18 and over COVID-19 vaccine compliance was way above the national median for these groups. We probably need to rethink how we can actually help them to communicate and use these as case studies for success. And we also, another summary is on the workforce makeup. These groups not only have less virtual type jobs, they also have lower rates of full-time employment. Many must work 2 to 5 part-time and seasonal jobs to make ends meet. Lack of employer benefits with part-time employment really makes it difficult for this population to be protected.
Right. Thank you very much, Ernie, for that great presentation.
Thank you.
Any questions for Ernie, please go ahead and put in the chat. Is that information anywhere on a website, some of the visualizations you presented, where folks can go take a look, or just within the slide deck?
Just within the slide deck, but we could definitely post that onto our Vizient website.
That's great. And do you have plans to continue to update some of that information as the pandemic continues?
Yes, we're always looking at this because we do, in our department, we do medical research. So we have lots of MDs and PhDs at the different hospitals working with us. So we're constantly working through different COVID problems. We're looking at myocarditis. We're looking at COVID-specific issues as well as other research areas.
Excellent, thank you. Okay, we have a question. Thank you for this presentation. Is there a difference between the Arc Svi and the Cdc Svi?
Not really. When we looked at the data, I actually pulled the raw data from the CDC and I looked at the one from Arc. And I did notice that they, there was a little bit of updating because the Arc one that we used was a beta version. So but the differences are very minute. That was a good question.
Great, thank you. Okay, that looks like all the questions we have right now. So again, I want to thank Ernie, and we'll bring back all of our presenters. If folks in the audience have any additional questions, please add them to the chat. I want to thank everyone again for all the wonderful presentations. We do understand how important the social determinant data is in identifying equity, access, and outcomes issues. So I'm going to go ahead and ask a question to all the presenters. Since you've all been using social determinants in healthcare data, where do you see the gaps and what are your thoughts on improving the data?
Well, I think one of the gaps right now, especially in the claims data, are whether or not knowing whether or not a screening has occurred for a social need. I think that without that information, it's kind of hard to determine overall prevalence or what the expected overall prevalence would be without having those screening data available. I do know that in Michigan there is some effort to further encourage these screenings, and we're collecting those, and I believe those will be collected outside of the claims data. But yeah, having information about whether or not screenings have occurred for a patient is really important.
Thank you. Others want to respond?
Yeah, I think there's also, we're all, even in my own work, otherwise, we tend to use really crude area-based measures, even just county-level characteristics. And I think it's always the best that we can do. But I think there's a real kind of ravine and conceptual understanding between area level measures and individual level needs. And so I think, this advancement of capturing those individual level measures is really critical, because there's plenty of people who are very healthy and very sick communities, and plenty of people who are very sick and have these needs in what would appear to be healthy communities. So I think that's a big, there's kind of always this effort to get more granular at the area level, but I think there's this real opportunity in our data, because there's a person in front of another person, this opportunity to collect at the individual level what those needs are.
Thank you. Would anyone else like to respond? Okay, I'm going to move on to another question. Several data sources were mentioned in your presentations. What additional or favorite data sources are available for doing this type of work?
So our analysis was based primarily on administrative claims. However, we did supplement that to a certain extent with various, especially geographic indicators, really originating out of public source surveys like the American Community Surveys. I think that that's an excellent database right there that includes indicators at various geographies all the way to typically census tract level. And so I think that's a really rich data set for measuring social determinants of health. And I know a couple of our other presenters, it looked like they leveraged those data as well. So I think that's a really important resource for us.
Thank you. Any additional thoughts?
There are also a couple databases that we use that combine different sources together on one place. So the Robert Wood Johnson Foundation has some data, the Opportunity Atlas. So it just kind of gives you like a one-stop shop for some of that ACS data, but also some other sources as well.
Thank you.
Yeah, and I would just say too, one thing that we found in our work of looking at these Z codes, which was interesting, is one of the big reports came out of CMS that looked at Z code utilization in fee-for-service Medicare beneficiaries, and that's really what drove a lot of the recommendations that Z codes are being underutilized, which they are, and the recommendations to not include social risk and VBP adjustment. But in our all-payer database, we actually saw that Medicare beneficiaries only make up about a quarter of those with Z codes, and about 40% are Medicaid beneficiaries, and then the others perhaps uninsured. So I think it's really critical to also understand the role of these Z codes within payers and how particular codes and domains of health-related social needs may be more prevalent in certain payers than others. I think any movement on CMS's front may be driven by Medicare data, but we need to also understand Medicaid and then, of course, private payers and all of that too. So I think regardless of the data source of claims, to look at these things, there really should be a lot more attention, I think, to how these things differ, because they will quite substantially, I believe.
Great. Thank you. So checking again. Okay, we have got another question. Let's see. Do you see challenges in standardizing gender sex identity measures? For example, given the high suicide risk, standardizing how and when to change sex on claims where patients are under sex reassignment. There are consistently unknowns and conflicts in the gender sex field on claims data.
My work didn't directly look at this, but this is something I've thought a lot about, because in all of our work, we frequently think about the quality of the data. And in the previous session, I think it was the last one or maybe two before, about the race and ethnicity and health data, there is a very similar thing that oftentimes we just don't allow multiracial, or it's a one column, and if multiracial is in a tick box, but you can see if those responses change over time. And so, does that change in response represent a data quality issue, or is it actually somebody reporting or a care provider writing down a patient's race differently on two different visits? So, and I think those same, we see that parallel certainly. Gender isn't actually really captured in any large administrative data. It tends to be sex, male, female, unknown. And so I think that's a big limitation, that we're just not capturing gender, and maybe that will be in the near future as we begin, and I think as we've all appreciated more, the role of sex versus the role of gender in care and outcomes. So, I think that's a really important point that I hope will kind of keep moving forward to allow these larger data sets and payers and researchers to be able to even ask or answer this question.
Thank you. Yeah, I think, because a lot of our data is derived from claims data, and some of the social determinant data elements aren't necessary for payment, it's been a bit of an uphill push to get some of that added to the data streams. But it is so important. So in each of your opinions, what would you consider the most important data element that could benefit from improvement, from standardization, just from collection in and of itself? If we can go around, Wyatt, why don't we start with you?
Sure. Yeah. I think Z codes are great. I'm a huge fan of them. But I think there's also limitations in that there's not been a lot of work to map them to social risk screenings and things. So although it might make for messier data, I would love to just have the social risk screening data kind of channeled up into claims or into large databases, or attached to kind of the person summary files. I think, we're still understanding what Z codes do, but I think if we can capture some of that social risk individual level data, regardless of how complete or incomplete it is, I think there's a huge opportunity there.
Thank you. Martin, any thoughts?
Well, I definitely agree with Wyatt's take on there. I would also, with some of these social needs screenings, I think we need to be very cognizant that patients with social needs may feel or may have certain concerns about expressing those needs. These are, that there are stigma attached to these, and so I think that that's an important thing to recognize as well. That just because a patient isn't admitting to experiencing food insecurity or some economic instability doesn't, again, necessarily mean that they're not experiencing that.
Great comment. Margaret?
Yeah, I was just going to piggyback off of what Wyatt had said about like the data collection of social needs into the claims data. I know that there is like a Gravity project going on to pull in social determinants of health data into FHIR compliant data sources, but I think that would be really important because not only like would we get the data, it's also standardized in some sort of format.
Thank you. Kelsey?
Yeah, I think we're all thinking about data collection here. I was going to piggyback off of what Martin said, which was just about thinking about how we can ask these questions to make sure that we're getting the most accurate responses as far as tracking these sort of social determinants of health characteristics.
Thank you. Ernie?
Well, I think the Z codes are really important. I just wish the compliance was just much higher, because when we've done small studies looking at Z codes in certain scenarios where we saw very good compliance with our hospitals, the stuff we could do with that data towards interventions and collaborations was so impressive. For me, it would just be a matter of how can we actually do those incentives.
Great comments. Yeah, I think, education and trying to get everybody on board with better data collection all the way around. So we do have one more question. Anyone have experience with EHR systems and or a healthcare system that collects patient disability status as a social determinant of health data element? So it sounds like none of our panelists have had an opportunity to work with data that has that.
I'll just put a plug here that colleagues at Mathematica that I work with might have had this experience. So, feel free to reach out to me via email with that question, and I can reach out to the broader Mathematica organization to see if they can answer any questions you may have.
Right, thank you. So it looks like we don't have any more questions in the chat. Does anyone on the panel have any closing remarks, a key point that they'd like to make before we end our session?
I guess I would just say, I think everybody here is in a position to have access to some data. And I'm, just very curious how other people's Z codes in these data elements look. I think, I have this worry that one day overnight CMS will change and Z codes will become reimbursable. And the reason I say that's a worry is that now there'll be this kind of explosion of how do we use them? How do we adjust for them? Can we add them to our, quality indicators? And so I think even though they're really underutilized right now, I think groups like these are the ones who can really address these problems and figure out, well, how the heck do we take 80 different ICD-10 codes and put them into both conceptually meaningful and practical categories of domains. And that's been a challenge right now, even with, these smaller data sets where we can look at individual patients and understand them. So I would just say, if anybody, nobody has free time, but I would just love to kind of figure this all out now. So that way I saw Alyssa had put in the chat, the day that CMS clues up and says, that we should adjust for social risk and we should reimburse for Z codes, that we all know what we're doing and we all know, how best to do this before things get too out of control.
That is a great point. I can see a little work group being formed here. All right. Any other last remarks? All right. Well, I want to thank all of our presenters. Those were great presentations. This is such a hot topic, and I really appreciate the time you invested in developing your presentations and coming here. Also want to thank again Comagine Health for sponsoring this session. And there is more to come today in the conference and next week. So stay tuned and join the next sessions. Coming up next, here we are. All right. Thank you all so much.